Hi, this is Tesha Monteith with the Neurology podcast. Welcome to our 2023 November headache series. We're doing it again this year because it was such a success. I promise you, we have some exciting audio programming in store. We're bringing on the leading experts to discuss the most relevant and important headache highlights on a full range of conditions. You don't want to miss this.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, welcome back to our November headache series. This is Tesha Monteith with the Neurology podcast. Today, we're discussing a really important area in neurology, commonly missed and lesser known primary headache disorders. With me to discuss is Stephanie Nahas, Associate Professor of Neurology at Thomas Jefferson University. Thank you, Stephanie, for coming on to our podcast.
Thanks, Tesha. It's great to be here.
Well, I really wanted you on this podcast. You're such an excellent educator, but I know you also like these kind of zebra cases, and you've talked a lot about them. And so, just kind of briefly, why are so many of these primary headache disorders frequently missed and result in diagnostic delay?
Mostly what's going to come to your clinical attention is going to be migraine, or it might be a secondary headache. And then folks just kind of tend to stop there. And everybody knows what tension type headache is like, and it doesn't usually require a doctor's attention. So people kind of get this laser focus of, oh my goodness, I have to make sure I rule out something scary. Okay, it's not something scary. I guess it's migraine. And so I think that's the kind of the dichotomy that a lot of folks fall into that trap. If it's not something scary, it's probably migraine. And you know what? They're right. It probably is, but it's not all migraine. And indeed, I even find myself falling into that migraine trap at times. So we have to remember that not everything is migraine, that there's a lot of overlap in headache presentations. This is one circumstance where a patient is very much allowed to have more than one headache diagnosis. And if you really delve deeply, oftentimes you can identify more than one just headache diagnosis. A classic example, I think, is occipital neuralgia. This is an entity that is both overdiagnosed and underdiagnosed. And what do I mean by that? Well, overdiagnosed, a clinician might hear some symptoms that are typical of occipital neuralgia presentation, and they stop right there. They say, you have occipital neuralgia. You have to go to the pain management specialist and get injections in your head or procedures on your nerve system, and that's the end of it. And they don't uncover the fact that this individual also has migraine, or maybe they actually have cervicogenic headache that's mimicking occipital neuralgia. Okay, so now on the flip side, we see somebody who clearly has migraine, probably chronic migraine, and they describe some symptoms that could be consistent with occipital neuralgia. And then we say, oh, yeah, that's just part of your migraine. Yeah, you just have some scalp allodynia. Yeah, you can get sharp shooting pains in migraine. It's all migraine. And we miss the opportunity to then address both entities with the best treatments for each and to achieve synergy in our therapy for our patients. So that's just one of many examples I could think of.
And then what about the trigeminal autonomic cephalgias? We have to talk about that because there's often a diagnostic delay with cluster headache, but then there are even more rare types of these, what we so-called TACs. So what are some ways that clinicians could better diagnose trigeminal autonomic cephalgia? Certainly talk about cluster headache, but then some of the other types.
Yeah, cluster headache is the key one, the critical one, the most common of all the trigeminal autonomic cephalalgias. This spectrum of disorders is relatively rare, but when you consider the fact that cluster headache is just as common as multiple sclerosis, why should it be getting missed all the time? I think there are a number of reasons. So number one, students, they all learn about cluster headache and they think it's really cool. There's like actual physical exam findings. There's something visible that happens to this person. It's really weird. It's really debilitating. And so they think that they can recognize it. They can certainly recognize it on a test, right? But they can't always recognize it when a patient sitting before them is telling them about their problem and that patient actually has cluster headache because the presentations are so heterogeneous. And again, there's often overlap with other syndromes, most notably migraine. We shouldn't always think, oh, if a man has headache, it's cluster. If a woman has headache, it's migraine. It certainly goes vice versa. And another reason that cluster headache goes undiagnosed for a long time is For most folks with cluster headache, they're only experiencing the disorder for a brief period of time, weeks to maybe months out of the year, maybe only one bout every several years. And so they miss that opportunity to get to clinical attention, or they have a number of barriers to getting to clinical attention once their bout of cluster attacks begins. And then by the time they finally see somebody, it's over and they say, oh, well, I'm not going to bother going to the doctor. I'll just wait and see if this happens again, right? I'm sure you've seen this in your practice too, that you don't wind up seeing somebody until they've gotten so bad because they've progressed from an episodic state to a more chronic and refractory state. And here again, we've potentially missed that opportunity to intervene early and prevent the disease from progressing. Something that we've never been able to prove, obviously, but it's a tenet that we hold dear. Early intervention yields the best results.
So why don't you help us with some clinical pearls when distinguishing between the different types of trigeminal autonomic cephalgias, for example, attack duration?
These entities are typified by much briefer attacks than something like migraine or tension type headache. Cluster headache attacks are the longest of the attacks within this spectrum, but they're still not all that long. Of course, you talk to the person who's dealing with cluster headache and they'll tell you they last forever. But on average, an attack will last for about 45 minutes, anywhere from 15 minutes to 3 hours. And they're very dramatic. The pain is excruciating. It tends to be side-locked. There's this expression of autonomic outflow and dysregulation when you get the ipsilateral tearing and injection, ptosis, edema, rhinorrhea, oral fullness, and most of all, the agitation and restlessness that comes with these attacks. It's almost like a Jekyll and Hyde scenario. Somebody before an attack is like a normal person, and then when they get into an attack, the monster comes out and it expresses itself within that person until the attack finally ends. Another critical clue to cluster headache diagnosis is the predictability, the periodicity, the rhythmicity of them. So on a diurnal scale, the attacks tend to happen at specific times of day. On the annual scale, they tend to happen at specific times of year. And they happen multiple times per day for weeks to months on end, clustering together for a limited period of time. And then months and months and months go by before the next cycle or bout of these things occur. That's why we call it cluster headache. Now, of course, there's the flavor of cluster headache, chronic cluster, where there isn't so much a clustering of these attacks within defined bouts or cycles or spells. They just go on every day, day in and day out for a year plus without any break, or only a brief break of less than, say, 3 months. Now, contrast that with the next of these TACs that I want to tell you about. And by the way, TAC, trigeminal autonomic cephalgia, that really describes the expression of all of these. Paroxysmal hemicrania bears the most similarity to cluster headache. The key differences are, number one, the attacks are not quite as long. Number two, there isn't that predictability in that circadian rhythm or the circannual rhythm. They tend to be much more random, but a key trigger for paroxysmal hemicrania attacks can be head turning, whereas a key trigger for cluster attacks can be alcohol consumption. Now, triggers are a whole other Pandora's box, and we could do a whole other topic just on triggers. But this is another thing to ask about when you're faced with somebody who's dealing with headaches and you're trying to diagnose what they've got. Paroxysmal hemicrania, unlike cluster, these attacks, they don't tend to happen for restricted periods of time and then go into long remission periods. Most patients most people who have paroxysmal hemicrania, they'll have it day in and day out, or at least every other day. And they'll tend to have a greater number of attacks per day, although they're less in duration and less in intensity. But they tend to have all the same associated features with the autonomic dysregulation. Moving on down the spectrum of the TACs are the Nahas syndromes, the short-lasting unilateral neuralgiform headache attack syndromes, which currently we describe in two flavors. SUNA, meaning just with autonomic features of some sort. You just need to pick one out of a list of a number of autonomic features. And SUNCT, in which the individual must have two specific autonomic features. The C stands for conjunctival injection, and the T stands for tearing. So with SUNA, you have one or neither one of those, but you have to have at least one autonomic feature, and that could include something like ptosis, for example. Now, the last of the attacks is a little bit of an oddball, and it made it into the formal classification within this spectrum only in the most recent iteration of the ICHD, and that is hemicrania continua. What's different about hemicrania continua? Well, unlike all the other attacks in the spectrum, these aren't necessarily discrete spells. As the name implies, half the head hurts all the time. What is discrete are the superimposed attacks of unilateral head pain with, again, an array of autonomic features. And these superimposed attacks tend to be very brief, although they could be somewhat longer. It's not really clearly defined how long those superimposed attacks ought to be to make the diagnosis, but a couple of things are clear. Number one, it has to be side-locked. Number two, it has to be continuous. And number three, there has to be these superimposed attacks with autonomic dysregulation as part of the phenotype. And finally, like paroxysmal hemicrania, absolute responsiveness to therapeutic doses of one of my favorite medications in the entire universe, indomethacin.
And you've been very consistent with indomethacin being one of your favorite medications in the universe. I think you've been saying that for at least 10 years. I'm glad that it's your favorite. Speaking of indomethacin, some issues with the attacks, especially the indomethacin responsive ones, are that patients may not get the proper indomethacin test. So why don't you clarify what an appropriate indomethacin test is and remind us about the potential side effects or adverse events associated with indomethacin.
Indomethacin, it's an anti-inflammatory medication of the nonsteroidal variety. So, of course, any concern or caution that goes along with any NSAID also goes for indomethacin, namely the potential for bleeding, ulcers, renal damage, etc., even hepatotoxicity. So that's kind of across the board for NSAIDs. Now, as far as NSAIDs go, indomethacin does tend to be a little harsher on the GI tract in my experience with my patients. Very rarely with any anti-inflammatory drug, there can also be some central effects causing drowsiness or mood changes or, kind of mercurial, strange kind of brain stuff. So I do caution my patients about that as well, particularly with indomethacin, because I've seen it more than a few times and it's really peculiar. I can't quite explain it. So that's kind of ground rules for safety with indomethacin. Then what is a good, fair try of it? I would recommend starting with a 25 milligram capsule, one at a time, 2 or 3 times a day with some food to begin with, because that might be enough. I have found that for some of my patients that are really exquisitely and dramatically responsive to indomethacin, between 25 and 75 milligrams per day is all they need. Now, if you're faced with somebody who you believe with 99.9% certainty that they have an indomethacin responsive syndrome and they haven't gotten better within the first few days of 75 milligrams, then you counsel them to increase the dose cautiously, but fairly aggressively. Just wait a few days in between each dose increase. And again, watch out for adverse events. By the time you hit 50 milligrams 3 times a day for a solid 2 weeks, if nothing has happened, nothing is likely to. Almost everybody responds by that point in time. However, there are a few individuals who will be stragglers and who will take a little longer. And some clues that you might be onto something are that they're getting a little bit of relief so far. So as long as they're tolerating it, I have them keep pushing it up to a maximum of 100 milligrams 3 times a day and let it settle for a couple of weeks. If after that point in time they aren't dramatically better or they're not tolerating it, I put it aside and we start exploring other treatment options. And I come back to the history because maybe the diagnosis was not correct. There are a number of cases of phenotype that suggest indomethacin responsiveness. But if you're missing a critical key element of a secondary contributor or cause and you're not addressing that, all the indomethacin in the world may not be enough for that patient.
Why don't we move on to some of the epicranial headaches described as pain over the scalp?
These are also some of my favorite because, again, I think they're much more common than we realize. We might be seeing a patient, their main concern is that they have debilitating migraine. But if you ask them and if you probe them, you'll find that they also have these other little headaches on top. And compared to migraine, they're like no big deal. So they don't really tell you about them. Or they think, oh, maybe this is just some weird kind of sensory thing with my scalp. Or maybe even they just believe, oh, it's part of migraine and I don't even need to talk to my doctor about it. But I think you'll see it a lot more often if you just start asking, do you get any stabbing pains in the scalp anywhere? That's stabbing headache. Sometimes our names are, pretty straightforward and they really describe the entity that we're dealing with. Nummular headache, that term comes from the ancient Greek word for coin. And that's because the headache itself is like in the shape and size of a coin somewhere on the scalp. And it tends to just be there and only there without any radiation, without any change, without any other associated features. And you might find it in isolation. But I've often found that patients may have a nummular spot of headache on top of their other existing primary headache disorder. Now, you also mentioned epicrania fugax, and this is a really weird one. Zigzag headache is another nickname that's been given to this because that's really what it's like. Imagine lightning bolts of zigzags sort of traversing across the surface of the scalp in a painful, sharp, or even burning or prickling sensation. These are very brief, but they can be very, very intense and very, very debilitating. Again, I rarely see these in isolation, but sometimes I do. When they're bad enough, a person will be motivated to come see a specialist about it. But much more often, I will see this in combination with something like chronic migraine.
So how common is nummular headache? And can you describe a case that highlights successful treatment?
Nummular headache is not all that common, but I think it's more common than we realize. Again, I think we don't ask about it quite as often. Technically, it should be an isolated entity, pain in one fixed spot on the head without any other secondary cause identified, like a skin infection or some sort of growth or what have you, and featureless. We don't really know what causes it. There are a lot of theories. The treatment can be very frustrating because we don't really have a lot of good directed treatments towards it. But a case that's very high in my mind, like this is a patient that I actually started seeing when I was a fellow, and I still see him. He came with a story of one day, it happened to be Thanksgiving. They were sitting down to dinner, and all of a sudden, he had a spot of pain that appeared in his left temple. It just turned on, and it was really pretty bothersome. And it never left him. So he came to tell me about this pain in the side of his head. And that's what bothered him the most. So I thought maybe this is nummular headache. I did ask him some more questions. It turns out he did have some migrainous quality some of the time when the pain would become very intense. He would become a little sensitive to light or noise or a little nauseated. But mostly it was just this pain right there in the left side of his head. And it switched on one day. He remembered clearly the date that it was. So here we have a guy who's got new daily persistent headache of a nummular phenotype with some migraine characteristics. All right, what am I going to do? We hear a lot of scary stuff here, right? Because new daily persistent headache really scares us when we hear that. It can be notoriously difficult to manage unless you take a systematic approach, and we could talk more about that later. But we also have nummular headache, this weird entity that we really just don't know how to treat it with. Plus, we've got some migraine mixed in. All right, so where do we begin? Where do I start? Well, being a specialist at a headache center, and mostly what we see is migraine, I'm most confident pulling out my migraine toolbox. So that's what we start exploring. Anything and everything that you use for migraine. And his case was really, really tough. We had to even go up to infusion treatments and even a hospitalization to try to get on top of this. And everything was working kind of, sort of, a little bit, giving him temporary results, but still nothing was completely eliminating this pain. We even tried local anesthetic injections right into the spot, which strangely didn't even make the spot numb. He could get numb other places, but not there. Really weird. Still can't explain that one. We even tried a little bit of a neurotoxin injection right into that spot, and it still didn't work. Years go by, and there's a neurotoxin that becomes approved for chronic migraine. So we decide to give it a try because he's still got some of that migraine flavor. So we do the neurotoxin injections, not just in that spot of where the pain is, but spread widely over the scalp of the forehead, the occiput, the cervical paraspinal muscles, and the trapezius muscles, the traditional injection pattern. And guess what? It worked. And the more we did it, the better he got. And in between his treatments, he was essentially pain-free. At this point, he's pushing 70 years old, and I think he's kind of outgrown the headache at this point, which sometimes happens because we stopped the neurotoxin treatments a long time ago, and we've been slowly weaning off some of his other medications. And now he just checks in once a year to make sure that nothing new has come to light, and that if things get out of hand again, he's still plugged in with us and can get our expert advice. That's a great illustrative case of a blend of different syndromes, not only new daily persistent headache and chronic migraine, but also this nummular phenotype. And a guy, too, right? So it's unusual that middle-aged guys come to see us. So this is a true zebra, like you say.
Yeah, well, I think it's interesting, and it tells us how much more work we need because we are really just have phenotype to go by most of the time. You did mention new daily persistent headache, and so I think now is a good time to talk about what that is and how do we treat it. These patients are often having a lot of suffering.
As the name implies, new daily persistent headache begins anew on a particular day and persists without remission. By definition, the date of the onset should be clearly remembered, and the headache should have become daily within 3 days. I've never seen a case where the headache started on Monday, was gone on Tuesday, came back on Wednesday, and then stayed for all eternity. Just about every case I've seen, it's been right from the get-go, constant daily pain. Now, I don't always encounter folks who clearly remember the day that it started, the exact date. They can say that it was like a switch flipped or they woke up that way. But for whatever reason, the exact date is not so clearly remembered, unless, say, it was linked to a special event or a holiday. For example, I've seen cases of new daily persistent headache that started on Thanksgiving or on Christmas or on Valentine's Day, or the day waking up from a surgical procedure, or the day arriving in a new country for a vacation after air travel across many time zones, or the day after a vaccine of some sort, any vaccine, and these links to how it started is so critical in formulating your treatment plan. Your plan of attack, your management really revolves around that careful and detailed history to try to uncover, all right, maybe I can figure out what started this. We know when it started, but can we figure out what started it? For example, if it was associated with a vaccine, okay, maybe we're thinking about some sort of systemic inflammatory type of a problem. If it started after a surgery, okay, maybe we're thinking of perhaps a low-level injury or strain to the neck from the intubation procedure, or somehow in the way the patient was positioned during the surgery, just some examples. So that kind of helps get you towards what may have turned it on. And even if that switch has been removed, the headache is still going. So now we have to figure out some alternative switch to switch it back off. Then in your history, you're also trying to uncover the key and critical aspects to the phenotype. Because when we don't have a secondary cause to go after, or when the secondary cause has been addressed and remediated, but we're still left with these symptoms, well, we treat to the phenotype. And so if it seems to behave like migraine, we pull out our migraine toolbox. If it seems more like a tension type headache or a cervicogenic headache, those are our targets for our treatment. And then we proceed from there in our usual trial and error fashion. But again, never giving up on this diagnosis and never being afraid to revisit the history and wonder to yourself, am I missing something? I'll tell you another quick case of new daily persistent headache that I like to highlight in some of my lectures on this topic. We saw a patient a number of years ago with a clear new daily persistent headache presentation, had migraine phenotype, not responding to migraine treatments, reportedly normal MRI of the brain, which we never saw until a couple of years later. And indeed, it didn't look that bad, but something about it just looked a little off. So we repeated it, and what seemed to be a little off on the repeat scan was clearly a little off. This patient had very thick skull and descent of the cerebellar tonsils with a crowded hindbrain. And what was really happening is that this woman was developing hyperostosis, and her brain was slowly being squeezed out of her skull, down through the foramen magnum and into the cervical spine. And so no wonder medications weren't working. She was, literally like toothpaste. Her brain was starting to be squeezed out of her skull. And the definitive treatment was actually a suboccipital decompression procedure that relieved all the pressure. Everything rose up. Her tonsils were no longer peg-like and descended down into the cervical spine. There was plenty of room in there. And her headaches got better and she didn't need medication anymore.
That's a really good point and reminder to always think about secondary causes. Oftentimes, patients have had many MRIs, but you have to take a look at that as well, right?
Yes, indeed.
Let's move on to hypnic headache. It's also a rare disorder and a very interesting one. Anything new about hypnic headache? And just remind us what hypnic headache is.
Hypnic headache, again, where the name is somewhat descriptive. Now you think hypnic and you think hypnosis. Oh, okay. So is this a headache that comes after you've been hypnotized? Is this a headache that makes you feel like you're hypnotized? No. The hypnic part of it implies that it tends to happen during sleep, fairly exclusively. And in fact, it's given the nickname of alarm clock headache because what a patient will describe to you is that in the middle of the night, they're just suddenly awakened as if an alarm clock went off, but it's not an alarm clock with sound. It's an alarm clock with pain, head pain, pretty bad head pain, typically described as moderate, if not severe, often holocranial and throbbing. But apart from that, not much in the way of a migraine phenotype. The headache tends to go away on its own after the individual is awake for a little bit. So they may have to get up and out of bed and walk around, and then eventually, okay, now this headache is just magically gone in a matter of minutes. If not, they may treat it with analgesics, and then it usually goes away, and then they can go back to sleep. But imagine having this happen night after night after night after night. And that's what hypnic headache is like. Now, for the lucky individuals with hypnic headache, it only happens 10 to 15 nights out of the month. It has to happen at least 10 nights out of the month for the diagnosis to be ascribed. But again, you need to identify or rule out, I should say, that there is a secondary cause. There was a good review that was just published this year in Cephalalgia, and I'd encourage anybody interested in hypnic headache to go ahead and read it, because not only does it go over the description and the epidemiology and the variety of presentations, it really delves into some of these more oddball cases, describing secondary causes which can include brain tumors, vascular abnormalities, systemic problems such as nocturnal hypertension or fluctuations in blood glucose. And in addition, we're identifying that hypnic headache doesn't just affect older individuals. It can occur at any age. And in fact, there are case series which have been reported of children with hypnic headache. So it's pretty rare, but it's a real fascinating entity that we still don't quite understand why it happens. But because it's linked to sleep, we think that there's got to be something rooted in the hypothalamus.
And why don't you share with us the best treatment strategies for hypnic headache?
This might surprise you, but taking a little caffeine before bedtime can cure hypnic headache. It doesn't make any sense to me. And in fact, why should taking caffeine before bed, something that we tell our patients never, ever to do, why would that work? And why would that give them a restful night's sleep? I really don't know. But somebody with true hypnic headache can have caffeine before bed. It won't keep them awake, and they will sleep through the night because they won't get an attack. Now, if a patient doesn't respond, if their hypnic headache, I should say, doesn't respond to caffeine or they can't tolerate it, then there are, thankfully, a few other options. And here's another one that you might not always think about pulling out of your headache toolbox: lithium. Lithium carbonate is considered among the first-line treatments for hypnic headache and for cluster headache, by the way. So here's another reason why we think there's got to be some link to the hypothalamus and why lithium works. Again, who knows? We have not unlocked that mystery, but lithium can work for this. Indomethacin, here's another role for indomethacin potentially. Of course, knowing that hypnic headache most commonly affects older individuals, you've got to be very careful with any anti-inflammatory drug in somebody who's in that older age set. Melatonin is also purported as a pretty benign, but often quite effective treatment option.
Great. I think that's really fascinating. We often think about older patients, but it's really important to keep an open mind to really get this diagnosis. So I want to move on to exertional headaches. There are a number of etiologies that can produce exertional headache. How do you approach patients with these differing presentations, whether it's related to cough, sex, or exercise?
This can be another frustrating and challenging spectrum of entities to treat, but that doesn't make me shy away from it. And I hope it doesn't make anybody else shy away from it, because you can be quite successful. And sometimes you can be the hero in these presentations. You do have to exclude a dangerous secondary cause. And primarily, we're worried about pathology in the posterior fossa or a vascular etiology. So I image all of these folks with a brain MRI, and I also look at the vasculature, including the veins. So a full look at the arteries and the veins, just to make sure that we don't have any funny business going on there. And then if I'm confident that structurally everything is looking good in the brain and the upper cervical spine, then we go on to treatment. And my number one is, guess what? Indomethacin. Here's another opportunity to use indomethacin, either daily or preemptively. It depends on how often the exertional headache occurs. So now if you've got an athlete who's got to train and they have to be taking indomethacin a lot, and they may be actually playing a contact sport, well, you may be a little hesitant to put your patient at risk for bleeding from trauma. So what are some other things you can do? Well, propranolol actually is reported to be quite helpful for these exertional headaches. If the exertional headache is also associated with increased intracranial pressure, then you have to address the increased intracranial pressure. So if structurally everything looks good and you've treated, but you're not getting the results that you're looking for, even in the absence of papilledema or other symptoms suggestive of increased intracranial pressure, look for that. The final thing I will tell you to look for, and I have not encountered a case like this, but I know colleagues who have. If you've got somebody who's a little older and may have some vascular risk factors, and they are telling you they have exertional headache, the alarm bells better go up for cardiac cephalalgia in those instances. Because instead of the cardiac ischemia manifesting in the typical way with chest pain, shortness of breath, nausea, diaphoresis, etc., with pain radiating down the left arm or up to the jaw, these folks, their only symptom may be a headache, and maybe with a little nausea, maybe with a little sweating, but hey, that's expected. They're exerting themselves, right? So you have to really be on the lookout for those cases, because if you send them straight to cardiology, get the stress test, get the cath, do the whole cardiac workup, and you find that they've got an occlusion in a major vessel, and then you get them treated and their headache goes away, not only have you helped them eliminate their headaches, but you've potentially saved their life.
Thank you for sharing that story. It's so important that we spread the word about cardiac cephalalgia. So thank you so much for summarizing this. I think this was great and very helpful in shedding light on these lesser known primary headache disorders.
My pleasure. Thank you for giving me a platform to ramble on and on about a topic that I hold near and dear to my heart.
Like indomethacin. Well, that about wraps it up. Hopefully this discussion will help improve your awareness on some of the most commonly missed and lesser known primary headache disorders. This is Tesha Monteith. Thank you for listening to the Neurology Podcast.